1% reduction, but importantly, a 53% reduction in cardiovascular events. ODC, which was done in patients already on a statin, showed a 62% reduction at the end of 4 years, but caused a 50%, 54% relative risk reduction in cardiovascular events. So it's not about statin, it's not about ezetimibe, it's not about PCSK9, it's a strategy. Get the cholesterol down and your risk for cardiovascular disease goes down. And that's the moot point in this debate. So I think I can get some noises. I hope everybody is mute. This is the recommendation from the ESC. Again, patients with type 2 diabetes at very high risk, consider 50% reduction to get the LDL below 55. Patients at high risk, less than 70. Look at the level of recommendation, 1A, 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 and the others as 2A, and only one with 3C. Glycemic control has not got this kind of recommendation in prevention of cardiovascular disease in patients with diabetes. So what would a strategy be? Glucose and hypertension, no way. It comes later on, but first thing is dyslipidemia. Statin is the foundation of preventive cardiology. So in summary, I would say diabetes is correlated with a high risk of cardiovascular disease. Managing diabetic dyslipidemia characterized by elevated triglycerides, elevated small dense LDL, high HDL, and elevated LDL is a crucial aspect of multifactorial intervention. LDL cholesterol has the greatest role in atherosclerosis, must be treated as aggressively as hyperglycemia to reduce coronary artery disease. Providers and payers must become familiar with current treatment. Lifestyle changes should be attempted before instituting pharmacotherapy, but dyslipidemia should be treated in all our patients. My boss, Varimani sir, is going to be angry with me. This was the kind of shock on his face after he was watching me talk, but he's a very good friend of mine, and I'm sure he's going to add a lot of value, because hypertension is the other risk factor which we need to treat to prevent any kind of vascular events, because we have twice the number of hypertensive prevalence in India as compared to diabetes. Thank you so much all for a patient hearing. Thank you very, very much.
Thank you, Aravinda. I think Dr. Karunesh Kumar can introduce the next speaker. So we'll have the discussion at the end, and people having questions can put in the chat box.
Dr. Karunesh?
Dr. Karunesh? I saw he's there. But
he's there. He's there.
Hello.
Dr. Karunesh?
Good afternoon, everybody.
Yes.
Yes, Karunesh. Yeah.
You put your video on.
No, video, it's not get.
Okay,
I'm not able to remove that. It is.
Right.
No problem. Carry on. No problem.
Please go on.
Yes.
Please go on.
Okay. It's a privilege to be in this very
Dr.
good
is waiting.
summit. I appreciate dynamism and enthusiasm of Dr. Aravinda to conduct this program. I want the slide, speaker's introduction slide.
Yeah, it is there, Karunesh.
So it's, I'm pleased to introduce Dr. Anil Kumar Virmani. He is MD, DRM, FICP, and many other degrees. Also, he is fellow of the Indian College of Physicians and Clinical Medicine, American College of Physicians. So he is chairman, Indian Associate of Clinical Medicine, Jharkhand chapter. He is also vice president, Clinical Cardiodiabetes Society at India. He is regional faculty, and he is faculty School of Diabetes. And he is also chairman, Scientific Committee, API, CSI, Jamshedpur chapter. And he is also past president, RSSDI, Jharkhand, and also CSI, IMA of Jamshedpur. He is founder member of Clinical Cardiodiabetes Society of India. He is a well-known speaker at many national and international conferences. So it's my pleasure to introduce Dr. Anil Kumar Virmani.
Okay, good evening, good afternoon. I hope I'm audible and my slides are visible.
Yes, sir.
Yes, sir.
Honorable chairpersons, my esteemed co-speakers, especially Dr. Rajiv Kovind, Aravinda, thank you. Wonderful conference. Before I start my topic, I must tell Rajiv one thing. Rajiv, you are a very good teacher. But I often ask some of my students, you see a patient with uncontrolled hyperglycemia and gross dyslipidemia, would you put him on a statin straight away? I'm sure you will say no. So that demolishes that you treat dyslipidemia first. Anyway, when this thing came, Aravinda told me it has to be a serious debate because the nation wants to know. But Rajiv sent me a midnight message, boss, let's have some fun. So I think we will have some fun also. See, when I started my career way back in 1977, I was told that all men are created equal. But 43 years down the line, I have realized, yes, all men are equal, but some are more equal than the others. And that is what I'm talking about. I agree glucose control is important. I agree lipid control is important, but perhaps blood pressure control is far more important. And that is what I'm going to prove in the next 15 minutes. Why? For the simple reason, the amount of cardiovascular burden hypertension gives and the catastrophic effects uncontrolled hypertension leads to are sufficient enough to prove my point. Now, we know that hypertension is the leading cause of cardiovascular mortality. There are about 10 million deaths per year. I don't think you see that with diabetes or dyslipidemia. Increased strokes, heart failure, chronic kidney disease. 30 to 35% of the hypertensive patients have coexisting diabetes. And similarly, hypertension is 1.5 to 2 times greater in patients with diabetes as compared to without diabetes. And this coexistence forms a very sinister alliance, and this leads to an increase in the cardiovascular morbidity and mortality. The prevalence of type 2 diabetes is galloping in India, and this is going to contribute a significant burden of hypertension. Unfortunately, less than 15% of adults worldwide have their hypertension controlled to less than 140 by 90. We see hypertension is a disease of three paradoxes. It is very easy to detect, but diagnosis rates are dismal. Easy to treat, but treatment rates are disappointing. Several potent drugs are available, but control rates are abysmal. And it needs a multidisciplinary and a multi-pronged approach. If you look at the burden of cardiovascular disease, the global burden, 50% is because of hypertension. And that also contributes to 50% of the mortality of the global burden of cardiovascular disease. The prevalence of hypertension worldwide was 26%, that is 972 million in 2000. And it is supposed to go up to 29%, that is 1.56 billion by 2025. And India is not lacking far behind, where we expect almost 150 million patients by 2025. India scenario at present, 25% rural, 33% urban. Of these 25% rural and 42% urban Indians are aware of their hypertensive status. Only 25% of the rural and 38% of urban Indians are being treated for hypertension. And only 10% of rural and 20% of urban Indian hypertensives have their blood pressure under control. According to sources from Ministry of Health and Family Welfare, by this year, 2020, our hypertension is around 159.46 per thousand population. Now, look at the state of Kerala, one of the most literate states. 1/3 of the patients are aware, 1/4 are treated, 1/10 are controlled. And this is the isolated office BP readings. This is the tip of the proverbial iceberg. What about the number of cases that are hidden if you do a full home and a 24-hour BP monitoring? And if you look at the both, we know that India is the world capital of diabetes. Every fifth person in India is a diabetic, and we are supposed to reach 366 million by 2030. And it is, unfortunately, it is soon going to become the hypertension capital. 1 out of every 3 persons is a hypertensive. And there is twofold increase in hypertensive population from 594 million in 75 to 1.13 billion in 2015. And 1 out of every 2 patients with diabetes has hypertension. But the biggest problem is the presence of hypertension leads to a 7.2-fold increase in mortality in diabetic patients. And look at the catastrophic effects. If you have a BP of more than 140 by 9, 59% of the first myocardial infarctions, 74% of the coronary heart disease, 77% of first, 91% cases of heart failure. And look at more than $65 billion is the cost. And according to the classification of hypertension, the risk, moderate to high risk, starts only when the systolic goes up to 160 and diastolic over 100. But when you have diabetes, there's a risk even at the level of 130 by 85. And if you have diabetes with organ damage, you are at very high risk no matter what the blood pressure. And unfortunately, we South Asians have a 40% more risk. And why is that? Are we different? Yes, phenotypes of cardiovascular disease, stroke, and heart failure, which are closely associated with blood pressure, are more common in Asia. And the association between hypertension and cardiovascular disease is stronger in the Asian countries than in the Western countries and occurs at an earlier age. We have more strokes than CADs as compared to the Western countries. And the slope of association between higher BP levels and CV events is much steeper in Asians. Asians are more likely to have higher BP even with mild obesity. They're more likely to have a morning surge, nocturnal hypertension, greater BP variability. And we also have a genetic predisposition to salt sensitivity compounded by high salt intake, as well as a significant seasonal and a regional variation. If you look at the north, look at the south. And do we have Indian data? Yes, here it is. The Mumbai cohort study, India cohort study. If the systolic goes more than 130, look at the number of strokes, jump in the number of strokes and the coronary artery disease. So what are the implications? Indians need to have a systolic blood pressure of less than 130 to have a good benefit. Now, what is the magic systolic blood pressure number that decreases the cardiovascular risk? Now, this is a wonderful study, the multi-ethnic study of atherosclerosis, where around 1457 individuals who were free from cardiovascular disease at baseline and a baseline systolic blood pressure of 90 to 129 and without any traditional risk factors were followed up for development of atherosclerotic cardiovascular disease. For every 10 millimeter increase in systolic, there is 53% more chance of atherosclerotic cardiovascular disease. And the risk starts right from the systolic BP of 90 to 99, the hazard ratio is 3, 100 to 109, 3.1, and 110 to 119 is 4.58. And we also see similarly the coronary artery calcium starting from systolic blood pressure of 90. So what are the clinical implications? We need to be more aggressive on interventions in preventing increased blood pressure. And this has to start right from school age. Healthier diet, low sodium intake, increased exercise, and even small changes in the blood pressure population level could result in massive changes in reduction in the cardiovascular risk. And we know that in patients, and there's a study where 1148 hypertensive patients with type 2 diabetes, when they were treated, the diabetes-related endpoints were reduced by 24%, deaths related by 32%, stroke by 44%, and microvascular endpoints by 37%. And this is, if you treat blood pressure to less than 140 by 90, there's a massive reduction in stroke by 27% and albuminuria and other all-cause mortality. The icing on the cake, look at this. Benefit of different interventions per 200 diabetes patients treated for 5 years. If you bring down the A1C by 0.9%, the benefit is you prevent 2.9 events. If you bring down the LDL by 1 millimole, you prevent 8.2. Yes, Rajiv was good. But when you break down this systolic by 4, you prevent 12.5 million events. So that is the importance of blood pressure. Now, even with the microvascular complications, blood pressure control has a greater effect than the glucose control. And what are the current recommendations? And these are that the threshold of starting treatment is 140 by 90, class 1A indication. The goal is 130 by 80 systolic, less than 130, but not less than 120. And in elderly patients more than 65, you keep it between 130 to 139, and diastolic less than 80, but not less than 70. And those who have very high risk can be treated even less than, the treatment can be started even when the systolic is less than 130. And these patients must also have the classical lifestyle modifications. I don't want to go to details. All of you know about it. And that is what even Faraz talked about. This. A RAS blocker is a must, especially in the presence of microalbuminuria or albuminuria, proteinuria, or left ventricular hypertrophy. The ideal combination is a RAS blocker with a calcium channel blocker or a thiazide or thiazide-like diuretic. And even in pre-diabetics, RAS blockers should be the first choice. And when you're starting patients on GLP-1 and SGLT2 inhibitors, remember that they're going to have an additive antihypertensive effect. All patients should undergo home blood pressure self-monitoring. And if wherever there is a problem, the patient should also have a 24-hour blood pressure monitoring done. So friends, hypertension is like the white whale in Melville's Moby Dick. It is evil, it is ubiquitous, and it is seemingly immortal. But I must not forget the Stella 2 study, and where the intensive therapy was compared with the conventional therapy. And that was, the intensive therapy was the dietary intervention, exercise, smoking cessation, use of RAS blockers, glycemic control, hypertension, lipid control. I must give due benefit and due recognition to all what my co-speakers have said. And this led to a reduction in 50%. Friends, but Aravinda told me the nation must be told something. And we learned one thing from this multifactorial intervention was that at the end, at a follow-up of 21 years, after 7.8 years of intensified multifactorial target-driven treatment, there was a net gain of almost 8 years of life. And that was free from incident cardiovascular disease. But having said that, what should the nation be told today? The nation should be told it is very important. I will come to that. But before I say, what are the implications in clinical practice? Benefits appear within 1 year of starting antihypertensive treatment. The number needed to treat is 20 to prevent 1 stroke, 10 to prevent 1 case of congestive heart failure. Patients are never too old to treat systolic blood pressure more than 160, individualize hypertension goals, and do not lower than 120 by 70. So the nation must be told, friends, the optimal approach to the reduction of cardiovascular risk in diabetes should focus on aggressive management of the standard cardiovascular risk factors rather than on intensive glycemic control. That demolishes my first speaker. Rajiv must be feeling very happy. But Rajiv, let me tell you the second part, what the nation must be told. And that is analysis of 67 risk factors. Worldwide, elevated blood pressure is a greater risk to living with a disability from target organ damage than elevated cholesterol, obesity, glucose, or alcohol use. Thank you, friends, for patient here.
Sir, over to Dr. Anand Moses, sir.
Yes, call upon all the chairpersons also to
Is there
join
scope
in.
for rebuttal?
Rebuttal.
Yes.
You can always shout the mic, Rajiv. There's one question in the chat box from Dr. Shekhar. He wants to know of the three which you consider important. Each one will say my thing is important, but I will give the chance to first Dr. Faraz.
Sir,
See,
Faraz, you can rebut yourself.
Yes.
See,
So if-
definitely, yeah, I think we all are treating our patients here and then stick to that first. Rather than winning or losing, I think all of us would realize that yes, it is very, very important to, yes, primarily in a diabetic patient, what do you want first? When a diabetic patient comes to you, are you looking for reduction in cholesterol, or the first treatment, first drug, what do you want to write? And then there have been a lot of studies as well which have shown, yes, primarily you have to get down the sugars, because if you see the CVOT trials also, the standard of care is based first on the reduction of glucose. So yes, we would not I would not deny on the fact on hypertension or dyslipidemia. I would not say that yes, we do not have to control that. But if you ask me, yes, I would say sugars would have to be controlled primarily, yes, along with hypertension. I would not say hypertension should go down. I would say sugars and hypertension have to be controlled primarily, and then we will look after the dyslipidemias. I think that would be my rebuttal.
Dr. Faraz, I think with the current thinking, the molecule you use for controlling the sugar becomes more important. What is your say on that? You can get
Definitely.
your HbA1c7 with various molecules, but with what molecule you use becomes of greater importance now. Your comment on that?
Definitely. I think now we are on this era where we are trying to look on the pleiotropic benefits, what we are getting with these newer oral hypoglycemic agents. So, gone are those times where we were talking about metformin in obese and sulfonylurea in lean. I think we have moved on from that. We have learned a lot from the Omnius octet as well. And now we have the very good molecules, as you were talking about. We have the SGL2 inhibitors, we have the GLP-1 analog. So these have clearly shown benefit, and then these are the drugs, yes, which would be used primarily after metformin to reduce sugars and to get benefit on the pumps, pipes, and filters.
Thank you, Dr. Faraz. Now, Dr. Rajiv,
Um,
you have
so
touched on LDL. You can talk on LDL, but can you give a
no,
comment on triglycerides?
I'll give a balanced view.
Please touch on triglycerides also.
Yes. So hypertriglyceridemia unfortunately has not been tested in a lot of randomized controlled trials, and that's why we do not have it being here right here. But if you look at GELIS, you look at reduce IT, the if you use the right dosage of EPA, you're going to get emergent risk reduction over a statin. So triglycerides actually, if you go through the discussion of GELIS and reduce IT, they say that the inflection point